All right, welcome to TIL Talks with Chris White, where we talk TILs, tumor-infiltrating lymphocytes, and all advanced cell and gene therapies, both with patients, caregivers, along with industry leaders. Let's get going. As a reminder, I am not a medical professional or medical expert. I am only a professional and expert on my story and my experience. If you are needing or seeking medical advice or assistance, please reach out to your care team. All right, what's up? What's up, everybody? Welcome back to another episode of TIL Talks. I have with me Dr. John Powderly from Carolina Oncology, Bioscientics with me again. I believe this is our fourth recording together, and super excited to talk about what's going on in the clinical trial space, the oncology space, and all things related. So just give us a little update what's been going on in the last month.
Yeah, so I can tell you about some of the adventures I've had because they might relate to your patient advocacy population who's trying to stay up to date. So I just got back last week from Barcelona from a international meeting about digital health, specifically how patients' electronic health records, or EHR, are coordinated or structured across different countries and how they can interoperate or how they might be able to be shared for public good. And so it's on my mind. I'm kind of excited about it. I gave one of the keynote talks there, got a lot of attention about what we're trying to do here at our clinic and also where the movements across the globe are going with digital health. And the name of the organization is called EHR, called Open, just like open for open source. EHR is EHR, Electronic Health Records, EHR, also pronounced Open-EHR or Open-EHR for short.
I love to play on the words.
There you go. Yeah. And so this was an organization that actually was founded at the University of London about 25 years ago with a very simple idea, that is clinicians, physicians should be able to structure clinical data in a way that physicians can understand the database, because they can build the clinical structure as a standard of which other doctors can adopt. And therefore, when medical record systems are built out, at their innermost kernel, their innermost core, they can interrelate with each other easily on a standards, open source, meaning agreed upon standard that clinicians agree upon, which sounds so simple and sounds so elegant, which is really cool. But what's happened is over the past 20, 25 years, with all the electronic medical records, it's dozens and dozens of great companies making medical record software. And the big push in America, as you know, we're trying to make digital records. This is a Medicare requirement. You've got to have meaningful use. Everybody's get out of paper, go medical records.
Yeah.
The problem with all that push that's happened in other countries, and especially in America, is it pushed the development so quickly that there were no good standards. And so, we went digital all right, but we went digital in such a way that we really didn't interoperate. And so it ended up being the best of breed software, but each best of breed software had their own proprietary database, their own proprietary application. The standards were not like congruent, and doctors really didn't have a say in how they think and how they type or how they organize their clinical notes. So what ended up happening is most of the modern software we see in America today are big companies, oligopolies. There's only a few of them that have kind of risen to the top, and they're proprietary. And so a lot of patients, and probably you and some of your audience, might feel like sometimes that a patient doesn't really own their data.
Yeah. Yeah. And that's a thing. That's definitely a thing.
And the data may be captured according to the way that the database proprietary systems were designed at the time. And they may not be that user-friendly to the doctors like me who, when I'm on call and I round at the hospital systems down the street and up the road, they're on different proprietary medical record systems, and the docs are typing notes until midnight or dictating until late hours. And when you go in and you round on a patient, you're seeing text file.
You need to see the most up-to-date information on that patient in real time to be able to help them as best as possible for what their current situation is.
And unfortunately, it's just layers of text files where you got to scroll.
Nobody's got time to read all that.
You got to open up the next text file. Oh, what did the nurses write? Open it up and read through
Yeah.
it. Oh,
It
what did
needs to be simplified and to the point.
so, and the reason it's like that is because clinicians in America, we kind of let it happen because the federal government forced everybody's got to move to medical records real quickly. And then they did, but there was no clear standards about how to structure that data. Just was Medicare just kind of pontificated top down. You must have meaningful use. You must track, did they get a vaccine? Did they stop smoking?
Yeah.
And so you're like, oh, check, 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 check. So
You hit the
doctors are just
boxes and
check in, and then typing, or dictating, and everything was unstructured, blah, 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 blah.
it sounds like the wild west of like the land grab of like, just go out there and get it and stake it. And then once you're there, that's just how it is. And there's no like, okay, well, is this going to work? Is this not going to work? How is this going to affect the future populations and the actual people that are settling this? But
Yeah. So a lot of the docs, they didn't have much choice because the small best of breed softwares that might have been very boutique or niche for their dermatology clinic or ophthalmology clinic or ENT clinic or whatever, the smaller softwares kind of, the companies weren't big enough to sustain and become centralized like the big hospital system software. So now most of the medical record software systems have all kind of merged under a few oligopolies, which I get it. And that's according to what the feds wanted everybody to be digital. But the problem now that we're stuck with in America is the systems don't interoperate that well. So the FDA, the feds had to come up with more standards on top of the initial meaningful use standards. They came up with more standards, which forces interoperability on a different standard. And the different standard interoperability works, but it's kind of like a band-aid of conduits.
yeah, it's not a permanent solution. It's just like for this moment.
It's still like text files and text files and text files when doctors log into a hospital system. And so the reason I'm excited about this conference I went to in Barcelona called Open-EHR is it changes the paradigm completely where, especially in European countries where Open-EHR started and it has spread to most of the European countries now are adopting it, and other countries in Africa and Jamaica and Australia for sure, and many countries in Asia, and also even in some in Moscow and other countries. The international doctors, how cool is this? International clinicians are saying, wait a second, we need to have databases which follow the way we as physicians take histories and do our progress notes and how we care about data. And the way we care
Interconnect.
about data is not just text files, and everybody typing their own thing in their own way they do it, but rather unifying upon standards where we can all agree, what is the definition of a blood pressure? What is the definition of how we record flu symptoms or a visit for a heart attack, or in our case, cancer symptoms and cancer management? So this whole movement is called Open-EHR. And after 20 years, it's really getting a lot of momentum. Listeners have to look it up, openehr.org. There are many, each country has an affiliate, and they've got, dozens of clinicians who are learning how to structure clinical data and having committees that kind of contribute to what's the definition of these different, for lack of a better word, data elements. They call them archetypes, like how you would describe clinical symptoms based on standard dictionaries of clinical terms. And then those clinical terms are translated into other countries' languages so that even if I'm saying a fever or a flu symptom or a heart attack, it's translated according to the same clinical structure for another country so they can understand what their definition. So it's somewhat congruent or synchronous, which is also a really cool thing.
That
So
is
it's
very important.
exponentially
Oh
adopted.
my God.
And the great thing is clinicians feel like they now can contribute to something with their peers as professionals in helping to define these archetypes as definitions of certain disease elements and symptom elements that they can put them into what's called templates of how they would structure common visits. And across country borders, doctors are agreeing and learning from each other how they would manage things right down according to performance status, physical function, memory, and using kind of the best clinical standards to make the best clinical database that is open source. And open source means that it's open to the doctors that want to use it. so they can adopt it. Doesn't mean everybody's going to know your clinical private records, but the structure of it helps doctors feel like they are empowered to design and configure their own medical record system.
Like a collaborative conglomerate of
Exactly.
agreement.
So that's the beauty behind open source, open data standards, and these data standards bodies. Open areas of data standards body. They're working with other data standards bodies like I big ones that will maybe look at data of how diseases are transmitted, disease control, public health, cancer data, to try to make the medical records more easily configurable and congruent. And the other big lift, which is probably the holy grail if we can ever get there, and some of the small, medium countries in Europe and in Asia, they're making it so it's a single database record that is
It's like a universal thing
bingo.
that
It's a
everybody
universal
can.
single patient record,
Yes.
single source of truth. Where right now, if you get any hospital you go to, they have a separate system. The systems
Yeah.
are not one-to-one data elements. Just things get
And
missed.
in that learning curve, what that does is it eats up time. And you know how important that is to like a patient when they're trying to like hear back from, their medical oncologist or their doctor. Like, I mean, time is precious, and like nobody's, when you hear, oh, it's going to be 48 to 72 hours or X amount of business days, you're like, as a patient, why is it so complicated? Why can't you take a chapter and make it a bullet point or a sentence?
Yep. It's because the systems, the electronic health record systems of big hospital or oligopolies,
Hmm.
they're good at what they do for capturing billing data.
Yes. Not summarizing the patient's, health history
But
and
everybody
how,
knows that if you go see a second or third, if you're a cancer patient and you go to second, third, and fourth opinions, you're writing the same thing, the same thing, the same thing over and over again. And you've been to maybe 3 or 4 different hospital systems, like your case history. Oh my gosh. There's no single database that has all of that.
I can see it all in one place, but all my separate organizations I visited with, they can't. And it's frustrating because it's like, okay, now I got to give you permission or send you the access so you can see it. And at the same time, it's so extensive. It's got to be able to be simplified and summarized to where they can get what they need at the point of access and then be able to help the patient and so they can continue to move forward.
Yeah.
That's
Even I would
huge.
even bet so much like the version that you see, of course, that's owned by the hospital system.
Hmm.
It's good and it's accurate for what that hospital system did. But if you're using other clinics or other hospital systems potentially on a different system,
Yeah.
or they're a small rural clinic in your rural
Yeah.
suburbs on the edge of,
They're not gonna see the same thing.
bingo. And when it comes down to medicine, continuous medications or allergies, or God forbid, cancer patients and the tumors are progressing and they want to get second and third opinions for access to clinical trials. This is our big use case.
Yes.
We're meeting patients from dozens and dozens of hospitals coming across state lines. And it's the same thing. We're still PDFs or faxes, or we look in the back door of some hospital systems, but the records are piecemealed together and they still are all text files. So you got to
Yeah.
scroll for
It's
an hour to
hours of reading.
pull out like the different text elements. So it's still a big frustration point, and all the doctors will know, and
Yeah.
patients probably get that too. So,
I think that's a universal issue that needs to be addressed and solved and like, I mean,
so those that are interested in just looking up or learning more, open.org,
openair.org. I wrote
openair.org.
that down here
And so
in
in
my notes.
they're working towards a universal care record, single
Okay.
patient record. They're working towards that. And countries like Spain, especially because they hosted it, they have different, like states or provinces in their country, like Catalonia, are completely on this record. You look at other countries like Australia and some other smaller countries where like they can't afford a big oligopoly system or proprietary database. They want their clinicians to work together to design how they do their structured data for their country, for their population,
Uh,
and they can use the same base elements so they can make it themselves. And it's one unified system. Makes it a little bit easier for all the stakeholders in that country.
yeah. And if that's where you're staying and that's where you're going, but globally, I've connected with patients in other countries that are going to other countries to get into a clinical trial or to receive treatment because it's not accessible and or available wherever it is that they're at. And then imagine all the logistics that go along with having to transfer all that data and then transcribe it once the person on the other end receives it so they can interpret it to be able to help, a patient as best as possible. So
So the
it's
cool thing about
incredible, man.
open air is it sort of discourages clinicians from just describing things,
And lengthy detail
length-
and like
it
paragraphs and chapters
makes them kind of fit them into these archetypes, for lack of a better analogy,
summarized
like Lego
points.
blocks of like
Yeah.
elements, so that the same doctor that's commenting on the same disease, it's the same Lego block, that definition, and then the attributes about that disease, the descriptors, the qualifiers, the start dates, end dates, those things are all somewhat unified on the same open source system. The beauty of this is we love it, and I'm so excited about it, is because I envision this as a way, if it gets adopted in clinical trial clinics like ours, we could embed clinical trials as data elements to be opened up more easily at other research sites to collect more efficient, clean data that is captured right there at the point of care. So
Yeah.
and so that was the clean keynote that I gave, and it was accepted with good accolades that this is possible, that's doable. We just have to get some FDA type standards embedded, which
Yeah.
we can build Legos around some of these clinical trial data standards. But if this ends up happening in the next 5 to 10 years, it'll make it so patients can, with their own single source of truth, look and see what trials they're eligible for as their tumor progresses or as their mutations shift or as they get more information. And then they can see if they're eligible just with clicks of buttons much, much more easily. And the doctors that do those trials or have the study open could then see them more quickly and easily. And so that's the name of the game for cancer patients, is how
Yeah.
can you get access to more trials through digital integration rather than having to fill out the same forms over and over again and describing everything that happened to you over and over again and delaying.
Gotta
Yeah.
tell you as a patient, it is one of the most annoying things I remember having to do is like just repeat myself like a broken record over and over and over and over again. I remember thinking like I've said this like umpteenth times to all these people that I've had to see. I'm like, why is it that I'm having to continue to repeat myself? Like, where's the place where I said it once and notated it and everybody can access it and like be able to understand it and like use this platform or they use this software or blah 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 blah. But I would just it was discouraging, and I'm sure like it's discouraging to a lot of other patients. I
It's
mean,
very frustrating
it
that
is
when you do that,
extremely frustrating.
most of the work that oncologists do, especially in the clinical trial business, is getting records, getting Rexer,
Yes, that's got to
pediatric
be streamlined.
staffs. And
That's the bottleneck. When people talk about bottlenecks, that is a huge part of that.
so if one day in America talk about reducing healthcare costs and trying to make it more efficient, if we agreed upon one standard that was modern and clinicians could define the definitions so they're built around clinical histories, not around billing codes,
Yes, yes,
but built around clinical histories of which the Lego blocks were color coded, and the symptoms that were around these clinician agreed upon definitions and storylines and timelines and tasks and labs, like avatar based, visual based. Then now we can get to the next stage
yeah.
of how to deploy trials and even help patients be able to manage their own symptoms
It's
if they can pipe into that single source of e-truth and help embed what their symptoms are from their patient reported outcomes.
I mean, it's almost like taking some text and being able to make like a graphic novel out of it, essentially, like to simplify, like a comic of sorts, to where you can look at something and understand it without having to have lines and lines and lines and lines and lines of text. You can like visualize it. And one of the things that I came across when I was in New York last week at the Association Value Based Cancer Care event was they had someone which during the main panel sessions in the main room by listening was able to draw like on I don't know, it's like a 4x4 like sheet, like a graphic that incorporates everything that was discussed within the session, to where normally if you were to take like a, what is it called, a stenographer, like type and text stuff
Yeah.
out, and it would be pages of text you would have to read that would consume lots of time. You could literally look at this graphic and understand everything that was said in that session, and within that point, and go, okay, cool, move on to the next one. And that just literally shaved like 9/10 of the time.
Yeah.
And this is literally the concept that we're talking about, is
Yep. Yep.
trying to simplify the complicated and make it understandable so you can move on to the next task and be able to help the patient.
And the technology in this space, especially around open air or open EHR, is moving so quickly that a lot of the cutting edge computer data science of like AI is moving along with it in a highly secure, we call small language model. You've heard of large language models where they're like, oh, generative, massive,
Yes.
massive data, which nobody wants to give their medical records to that big open sea. But they're now making super ultra smart, ultra focused little versions of smart AI kernels that would know only your data, and they'd stay only in your data policy and only know about you, and none of that data would go out. But yet they're trained in experts for cancer symptoms, for example, our use case, or they're trained in the next layer would be, oh, they're trained in getting things efficiently scheduled and coordinated. And the coordinators are talking to each other at the digital level. The experts are talking about symptom management, and they even can coach individual patients about their symptoms, which would be the future dream. Patients don't know how to describe their symptoms sometime. And a lot of the art of good doctors is letting them go from, I feel terrible, I feel horrible, I don't know how to describe it.
Rated on 1 to 10, blah, blah,
Yeah.
blah. Yeah.
Try to doctors can really kind of try to put it into categories that might make sense from a diagnostic workup. And a lot of that supervised physician training can be done that doctors are experts in their field. Like me as an oncologist, I think I've been managing cancer symptoms for 20 years. I think I could design a great little agent to just do that really good, where patients aren't giving away their data to a big open worldwide AI, but a little AI that only knew them as the single source of truth and kind of followed in on their symptoms and followed through with the training I would give them. And some of these open air systems are getting that good where it can be single source of truth, highly secure. The policies around those data elements are so protected. And then also within that, have some smart little agents, if you will, that are experts just in that type of cancer, or imagine just in immunotherapy
That'd be
effects.
incredible.
That's where and then embedding in access to trials as at least like, oh, dear patient, sorry, the bad news, you just progressed to stage 4.
Where do you go next?
Here's your
You
options.
want to automatically know, what's plan B, C,
Bingo.
D, E,
These
F.
are the questions you want to ask your next doctor. Here's the nearest center that has this study drug. Like those are the things that should be built into a single source of truth on open data standards that use medical dictionaries of Lego bricks of clinician supervised open source clinical data structure. And that's not a lot of the antiquated systems that have kind of risen to the top of some of these oligopolies are. And plus, they're owned by a large corporate entity. And really, it should be physicians with patients as a mutuality in a provincial type of way where patients are stakeholders in equal access, equal shared, and patients can decide who they want their data to be shared and who not, or managing their loved ones' data. And right now, that's hard to do in the current broken healthcare system.
It's extremely annoying to have to always change your password because you get a notification that, your data got leaked due to whatever. I mean, I got them today on a handful of things, and I'm like, what?
Yeah.
Oh my God. But oftentimes, and this is true across the board, is you have to check the little box and sign these consents that are enormously long and often not just clean and clear on what it is you're doing, but you have no choice but to click that box to move forward. And therefore, patients they don't really know what they're signing or what box they're checking, but they know that they need to continue to move forward. So they just go ahead and do it.
Yeah, you're totally right. And a lot of them don't realize when you sign those things, it sounds bad, but sometimes you don't realize that your medical records are not really your medical records.
No, you're just giving access to anybody and
You're
everybody,
taking
and
your
it's
history and also
your
the
name,
same
image,
thing,
and likeness in perpetuity to the universe. I mean, it's like,
even some of your own box using your own tumor samples, your own paraffin wax, your own scans, images
Yeah, I
of
can only
you.
imagine how many people have read my records.
And so the way the system has to be at the way it is now, but we can do better. And part of the take home message of this open air thing was at the end of the day, health data collectively aggregate all the patient's data should be part of the public good so that diseases and cancer and potential cures and trials, when people volunteer as a hero to be on a trial, it should be easy for them to volunteer.
Yeah, it shouldn't be a complicated process.
In those patients who check the box that they do want their data elements, not their name and address, but the data elements of did this drug work or not work, or how quickly did the cancer grow, unfortunately, or not, or what were the clues about their clinical symptoms. To have those clinical data structure be supervised and run and governed by doctors, not insurance companies and big hospital systems that are corporate or monetizing it so much that it kind of shifts it 2 or 3 degrees away from the public good. Because there
Yeah,
is no single source of e-truth right now. It's just whatever hospital system has it, has it. It's very, very hard to get that single source of e-truth. And that those interfaces, the conduits are very difficult to they're proliferating. The conduits are proliferating, but that means the complexity of managing those conduits interfaces is just proliferating at an exponential scale of more complexity.
it almost kind of reminds me of like pre-authorization. Like those that are in charge of approving or denying that, they don't necessarily have all the background to be able to do that. I mean, they have maybe a chart, like you said, some boxes to check to hit this or not that, but they don't have like the whole picture. And it's like if their oncologist or their doctor is recommending that they ought to be able to do this, like they're doing it with good reason. And it's almost like the same analogy of exactly what we're talking about. There's a miscommunication, there's a disconnect within the system and within the platform, that it's nothing's universal in a sense, or everybody's got their own platform or app or whatever it is, and there's that learning curve. And
Yeah.
again, we're back to like that just eats time, and people don't have time for that. Like it
Yeah.
needs to be seamless, and like I said, those bottlenecks, this is one of those things where it comes in.
So if your listeners want to read one of the great champions of this movement, I call it the open air movement. It's a patient named E-Patient Dave. E-Patient Dave. So if you type in E-Patient
I'm
Dave,
writing it
you'll
down.
see it. And E-Patient Dave, he had some loved ones, in particular, a close loved one that access to a clinical trial treatment option couldn't happen fast enough because of delays in getting records from A to B and B to C. It led to weeks and weeks and weeks delay. And he saw it personally affect somebody's life. And he's an engineer. He's not a clinician. He took it upon himself to take a deep dive into the broken digital health systems that are all these disparate data silos and how difficult it is to get the full clinical picture across data standards, even though patients can pop in the back door and say, yeah, I'm going to update my schedule of my appointment and I can get my pharmacy records and my billing statement. And they think it's unified, but it's really not. It's just still piecemealed at the back door. It's not truly a unified open source, open data platform. So anyways, he has been very involved, spoken at 2 of these open air meetings,
I
and
just plugged him in the internet and looked him
he's
up, dude. There's
awesome.
pages of this guy.
And he
Like it goes for
summarized it,
days.
this exact topic. He's on this crusade as like a patient himself and loved one patient
Yeah.
who've run into hassle after hassle.
Wow.
And his like, I mean, there was not a dry eye in the whole meeting in Barcelona because he basically used the analogy of like Obi-Wan Kenobi beaming in a hologram to the young Jedi.
You're my only hope.
Yeah,
Help me, Obi-Wan Kenobi. You're my only hope.
you must save the universe from the evil emperor
Yeah.
because you have and what he
Well, I'm
was
following
saying,
him right now on Instagram,
so cool.
X. He's got a
It's
TED Talk, YouTube. Like,
he is awesome. He basically says that
I'm gonna DM him, dude.
force be with you is like was
My God, how big of a Star Wars fan I am. You've seen
there
that
you
thing
go.
in my other room, right? My
Yeah.
Vader. Yeah.
So he's putting a
You
twist
got to
on.
connect me with this guy.
Yeah, he says your force, and he put it from an engineering stance down to real world, Star Wars analogies. The
All
force
day
you
long.
wield the force you wield is truth itself, and the truth is the single source.
Yeah,
So when we can
100%
get
talking my language.
clinicians and patients, it'll start with cancer patients because they're the one that care the most. Like nobody cares about their data more than a cancer patient. That is your mobilizing force is cancer patients. They're going to want access to a single unified source so they can get on trials and personalized medicines and
They
get
wanna
immediate
know as
results.
much as they can, as fast as they can to have
Bingo.
the best
They're going
options
to want
for
to get plugged into
survival,
this more than any
quality
other
of life.
use. All of the other groups. So, but yeah, that is it's not the force be with you. It's may the truth be with you as the single source of truth, which is a unified system. Everybody's on the same page, and companies can build their apps on top so they can look at all different ways they want to look at growth curves or data logic. That's great, but the actual Lego brick data elements should be agreed upon by clinicians, not billing coders based on billing codes,
Yeah.
which these systems were built upon billing codes, but rather how do clinicians think? How do we parse diagnoses based on the grade of the diagnosis or the stage of the cancer or what types of druggable targets are there? That those are the Legos in this system. And that's important. That's totally opposite of the way the current broken healthcare digital system works.
Yeah.
Eventually, doctors won't be typing notes all night. They can just have an avatar and just like paint the avatar a different color based on what organ system is being affected and design things that are more graphically
It's
integrated.
almost like that, Tony Stark
There you
deal
go.
from Iron Man where he just kinda, like, does the motions with his hands and he can just move
Some of
things,
these,
and
so some
same
of
thing
these
with that movie with Tom Cruise, God, like 10 or 15 years ago, man, I'm forgetting what it's called. It was, like, where they could see into the future, and yeah, and he was,
yeah,
like,
yeah,
doing
yeah.
this, and,
So, like,
like,
still
that's a real
today,
thing.
even as high tech as our clinic is, we have the best of breed software from everything, and they still don't integrate with each other. We still get faxes and
You
PDF.
got, faxing machines.
I
Oh my.
print them out so that I can get through the first initial visit. So now at Barcelona, we saw demos. I can't make this up. They're open air, single source database demos where doctors are contributing, thousands of clinicians speaking different languages from different countries contributing, and they can read through ocular recognition, read through all the blah 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 of like the facts,
Skip to the main
and
points and
put it
get to
into the
where you
Lego
need to
blocks,
go.
put it into the Lego blocks. So now it's part of a unified system that's agreed upon. It's not like corporate, arms races of different big corporate companies.
It
This is
reminds
just
me of, like,
listen.
step therapy. You gotta do this before you
You
go to
know,
that.
yeah,
It's
this is where
annoying.
Europe is adopting this hardcore now. You see in other countries, Europe, Asia, small countries that just don't, they're leapfrogging over the big monolithic, enterprise proprietary systems. They're just going straight to open air. So hopefully in America, we can raise the awareness through ePatient Dave and the openair.org, just so the
Yeah.
patients know about that this is a movement that's coming.
I mean, like, no matter what I'm attending or where I'm going or what I'm doing, like, it's the advancement of technology and software in healthcare and is just evolving and moving so fast, it's hard to keep up with. And before you boom, there's the next innovation, followed by the next one. And, oftentimes people hadn't caught up to the previous three and they're still on like six before that. And it's like, man, that's ancient history. What used to be pretty standard for years and years is now changing and evolving so fast and quickly
Yeah.
that these are the things that is the pace of today.
Yeah.
And that's also the same thing that, is going to help evolve the healthcare system. But ultimately, and the whole point is save patients' lives.
What if so if patients raise awareness about this and read about it, and imagine a day when clinicians and patients could have a single source of e-truth. Then if you go into Hawaii, you get in a car accident, nobody knows you're on a blood thinner, or you're allergic to something. And in that kind of security,
You could have like a
trusted,
bracelet with a QR code that could go directly and go, "Boop, here's the summary of this person,
and it's a
everything you
public,
need to know. Like
yeah,
they're allergic
here's
to
a public
this,
good.
they're blah, 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 blah. Here's
It's regulated like a public good, governed by physicians, not governed by a government. I don't think patients in America trust their government. So, but they would trust their doctors, I hope, and trust, other clinicians who are fighting terminal cancer to be
That's
on.
why they always say get a second opinion, a third
Yeah.
opinion. If they all agree, And then you're like, hey, they all agree. But if you're getting 5 opinions and have 5 different outcomes, you're like, what do I do? Where do I go? But if they're all on the same page,
Yeah. But the other beauty to that is if they do agree with slightly different angles,
at
having an
least you know.
online system might be synergistic because those different angles may put together more brains looking at it in real time than
It's like
just
a different view from a camera angle.
time.
It's
Oh,
the same picture,
now this
different
did, yeah.
view.
Yeah. And they could be perpetually linked to your records if you want them to, so they could continue to provide input if you ask them to, because the records are getting automatically updated in a single source of truth.
Yeah.
So yeah, I'm excited. It was a great meeting.
Something that's greatly needed, dude.
Yeah.
Like, what else did you take away from
I would probably say that open air, that was one society. The other things I've recently spoken at was like the North and South Carolina medical cancer meetings, cancer society meetings about phase 1 trials, which that's a becoming more and more interesting quote. I gave this in Barcelona and down in the Carolina Oncology Association. There now are 9,000 cancer drugs in development. So they're not all in phase 1 trials or phase 2 trials, but they all are in the pipeline, recognized new molecular entities listed.
are you talking about discovery phase? Or are you talking about
A
post
little
phase
bit
one or
beyond
just everything
discovery,
in between?
enough beyond discovery that they have been recognized as like an early drug in the pipeline. So it's not yet
Potentials.
in the phase 1, but 9,000, that's within
It's a
the
lot.
scientific literature or within like the corporate, small companies
Yeah.
across the whole globe. That's a huge pipeline. And there's 2,000 cell and gene therapies in development as of the latest statistics, which is awesome. That's the good news. The bad news, talk about statistics, is we look at the silver tsunami, all the cancer patients as they get older, cancer's on the rise. They're now predicting that by like year 2050, there's going to be some like 30 to 40 million new cancer diagnoses globally. And then also globally by 2050, be 105 million patients living with cancer by 2050. The number of oncologists is going down.
The number of patients is
The number
going
of
up.
patients is going up. Rural hospital systems are closing. So we have a real big,
There's a gap
it's
right
a
there that
big gap
gotta be
and in
bridged.
the globe as to how to handle all the cancer tsunami and the COVID stage migration because people didn't get their colonoscopies or mammograms or prostate
Yeah.
exams during the pandemic. So we're seeing more stage 4.
There's a melanoma patient that I had connected with where she missed her skin check during the pandemic, and she didn't normally do it, skip a skin check, but that skipping the skin check, by the time she finally did go get one done, and they got a biopsy, led her down the path to where she ended up having, a major case of melanoma, survived and everything, but it's the real life effects of not following up on your healthcare. I
Yeah.
mean, like,
Well, the other thing that is we're hearing just in the R&D space is the number of early detection for cancer
y-
tests. They're
yeah,
starting to get in more trials. I wouldn't say anything's like a home run proven yet, like,
no,
fully
but
FDA approved,
they
but the
have
number of trials,
ctDNA, they have all these kind of different labs, and the age for getting pre-screening for certain cancers is coming down from what it used to be. Like, now I think it's at age 45 to get a colonoscopy, which used to be age 50 or higher, just for example, right?
yeah,
I
yeah.
mean,
So these tests, the technologies for early cancer detection are moving along quickly. Some of them are so-called cleared, right? They're cleared by the FDA, but
still a
the
work in
jury's still
progress.
out on they just collecting more clinical data, but it's looking promising. So those are coming, and I think that'll be the next 5 to 10 years. We're now going to see routine primary care docs doing early cancer detection with blood work or urine samples. I think that's coming. So
Yeah.
good.
I met a handful of extremely interesting legends within the world of oncology and healthcare last week in New York. One of them I want to mention is Dr. Steve Rosen, stellar dude, head of City of Hope. I met another gentleman by the name of Doug Long, which runs he's on his like farewell tour of attending events towards retirement, but just had the most stellar outlook of like where things are going based upon where things have been. One, I would never imagine I would be in this room. Scott Gottlieb from the
Yeah,
FDA was in there.
great. It's great.
Cynthia Fisher, Mark Cuban, just all the guys from Swim Across America, the AVBCC. I mean, just the where things are going right now with the healthcare system and in oncology, especially within cell therapy and clinical trials.
Yeah.
I am super excited that you're able to bring up and talk about having this universal system for access in order for doctors, no matter where they're at, to be able to connect a patient's history and data information so they can be able to aid and assist them in the best way possible for them at that moment. You know what I mean? Like,
Yeah.
that is something that the patient community talks about all the time and is super frustrating, is that if they have to go from one place to another and they're having to be the middleman for themselves and they just don't always have the energy.
Yeah. It would be great if clinicians could look at one field user interface of how data is presented in a clinical standard way to know how a patient's doing.
Yeah,
Not have to read a volume of text files to get the mismatched history put together. And then patients to know how they're doing as well, because they could see it in a single place,
absolutely.
updated, curated in a single place. So I'll keep you updated about that. But that was fresh on my mind. So
Yeah.
you,
No, please do. I mean, we're approaching the final stretch of like the fourth quarter of the year. And like I said this in a post earlier this week, which is like the fourth quarter is the most important quarter. Like, no time to
yeah,
let up on the gas. You keep that
yeah.
foot down. You keep rocking and rolling. What's on your radar throughout the rest of the year that you got
Um,
going on that's
so let's see. I'll be at
popping?
the Society of Immunotherapy of Cancer annual meeting, which is in
It's
Maryland.
Virginia, Maryland. Okay.
Yeah,
Yeah.
right there at the National Harbor, which is right across the Potomac River,
Okay.
across from
Yeah.
downtown Alexandria. I've got a few abstracts there on some of the phase one trials. And then I'll be at my Georgetown Med School 30-year anniversary, reunion anniversary, which will be kind of cool.
Right on.
Yeah, Deloitte in Boston in a couple weeks. So I'll catch up with
Phenomenal.
leadership. So still moving and grooving. And when that presentation from Barcelona comes out, I'll ping you on LinkedIn so you can read
Yeah.
it
I'll definitely like share
and
that and spread it
yeah,
amongst the community. I'm
yeah.
super excited to read that.
And we're still opening up a new study about every 3 weeks. So for the community with stage 4 cancer, we're happy to give second opinions by remote consultations, and or see you to see if you're eligible for immunotherapy early phase clinical trials. So yeah,
100%. And as I always tell everybody, I have hyperlinks on my website. Like, go out there and explore. It's all about education and awareness. That's why I'm doing. And so, phase one clinical trials, I cannot say how important they are and how many success stories that I've got from the patient community. And so, if I would have known what I know now, I would have definitely looked into more of those early on in my diagnosis. Just didn't have the knowledge about clinical trials like I do now. So thank you so much for what you're doing over there, John.
yeah, no problem. Thank you very much. All right, well, I'll sign off here.
Yeah,
And
no worries, my man.
yeah, in a few weeks, probably when I get back from Boston.
Thank you so much. Take care and peace. All right, that concludes today's episode of TIL Talks with Chris White as we talk TILs, tumor infiltrating lymphocytes, and all advanced cell and gene therapies. As a reminder, I am not a medical professional or medical expert. I am only a professional and expert on my story and my experience. If you are needing or seeking medical advice or assistance, please reach out to your care team. I'd like to thank my guest today for joining me on TIL Talks. To our listeners who have not yet done so already, please follow, comment, subscribe, share, and smash that like button. For more information about TIL Talks and related resources, please visit www.tiltalks.com. I'm Chris White. As always, sending love to everybody. Peace.